folks can hear. Okay, so we're going to actually start this morning looking at identification and interventions of clients with dysrhythmias. Okay, the reason we place so much emphasis on dysrhythmias is probably one of the leading problems following a heart attack. Okay, it's one of the most pressing problems that we see because dysrhythmias, especially ventricular fibrillation and ventricular tachycardia, can lead to death of these patients after an MI. So that's why we really focus on this. And those are a couple of the ones. There are several rhythm strips that you need to know before you leave this program, and I promise you, you will know those. Did you need to say something real quick? Let me hit pause. There we go. Basically, as I was saying, the one reason we look at dysrhythmias is dysrhythmias are one of the leading causes of death after an MI. Also, other dysrhythmias can cause decreases in cardiac output. And in many of these patients, especially after an MI, we don't need to decrease that cardiac output. We need to keep it up at optimal ranges. First part of this we're going to go through fairly quickly because it should be a review for you. A lot of this was covered in Nursing 105, so you should have that for you. I hope you found I actually put up the PowerPoint slide for you, slides this time for you instead of the notes, so that you could actually have the rhythm strips to look at as part of your studying. So hopefully that'll be a little bit helpful to you. As Ms. Miller said, any of you who are interested, I will be doing a study session on Friday at 9 o'clock in the morning, hopefully here in 109. I haven't got the room set yet, so we hope right here. So I'd meet kind of out here in the vestibule lobby area until I get something, and I'll let you know. Second thing today, just kind of housekeeping. We have guests in the building today. We have people from all over the campus in room 105 in a seminar going on. So please, if you go out at break, try to be quiet, not too loud. Put your lab coats on as you go out because the dean and the president are looking, okay? So make sure you have your lab coat on as you go out as well, okay? So just some housekeeping. Now, on Friday, I'm not going to be re-lecturing anything. It's a question and answer driven type process. So study before then. Come with your questions, okay? Go ahead, if you've got your clickers, bring them, because we may go through a clicker test just to see where you are, where the class is as far as doing this. I have a clicker exam already set up, so we may do that as well. But it is for your benefit. It's not mandatory. It's all voluntary. If you want to be here, that's fine. We may, get some different aspects as far as somebody else explaining some rhythm strips, those type of things if you're still having problems. Sometimes hearing it from someone different is good because they may be able to explain it in a different way that I do. We have some experts back up here in the back corner that can probably teach it just as well as I can when we look at rhythm strips, okay? So as we go through, I'm going to go through that because all of that you've gotten seen. You've seen the skillstat.com. I've put that up for you before, and it is a good place to go practice looking at rhythm strips. You can click on the strip that you want to see it go across. You can freeze it. I don't know if she knocked me out of there or not. Yep, she knocked me out, so we won't go back there. Easily got on, but we'll pull it up a little bit later at the next break so you can take a look at it in case you haven't, okay? There are some different things. I'm sorry that WebCT thing is gone. I forgot to take that off. I apologize. But there are several type things. There's a psychnursecom.com EKG primer. It's a PDF file, but it has some interesting things for you there too. Now we've kind of gone over this, but let's quickly talk. What's the major pacemaker of the heart? The SA node, okay? What's the rate of the SA node? 60 to 100 beats per minute is normal, okay? From the SA node, you basically have the impulse going out through the intranodal tracts, which actually excite the atrium, and then basically you have a tract straight down to the AV node, okay? The AV node is your secondary pacemaker, okay? And what's the intrinsic rate of the AV node? 40 to 60. You may hear it called junctional as well because it's kind of the junction between the atrium and the ventricles, okay? So the AV node, what the AV node does, it actually slows down the impulse so that the atrium have time to contract and pump blood into the ventricles before the electrical activity gets there. Think of the AV node as a principal. Kids are running in the hallway, running. They see the principal, they stop, they slow down until he turns his back, and zoom, they take off again. So just that AV node is going to slow things down for us. Now, you can have problems with blood supply to the AV node, and it actually can block all the impulses coming through the system. Can block all of those coming through the system, and we'll get into what we call our second degree and third degree heart blocks, or complete heart blocks when we talk about that. The rest of it you can look at, you basically have your bundle branches, your right and left bundle branches. Then you get down into the fascicular type areas and branches, and then into Purkinje fibers, which get into the muscle themselves. We've talked about this, the SA node, the primary pacemaker, okay? As we go through that and looking at those, the SA node discharges 60 to 100. Bradycardia, when we start looking at rhythms, bradycardia is a rhythm less than 60 beats per minute. Tachycardia is a rhythm greater than 100 beats per minute, okay? So if you see those, typically what you'll see, if it is exactly 100, okay, if you do a rhythm strip and it is exactly 100, we will call that a tachycardia, okay? And as we start talking about this, we actually, as we do rates on rhythm strips, they're going to be in intervals of tens, okay? 50, 60, 70, 80, 90, 100 as we do these because of the way we're going to do it. There are more exact ways, but as beginners, we're going to go that way for you. We talked about the internodal pathways, Bachman's bundle, which is just part of that bundle branch system, the AV node. Remember, the AV is the backup pacemaker. And the AV junction is where the SA node joins, excuse me, I didn't change that. It's where the AV node joins the bundle of His. I thought I'd made that correction. But if the SA node fails, basically that AV junctional tissue takes over and initiates the electrical activity. Bundle of His. You can also get, basically, as you get down toward the heart itself and down into those bundles, you can actually, heart can be, those cells can actually be their own pacemakers. And typically you're going to see a rate down lower in the heart of more like 40 beats per minute, 30 to 40 beats per minute. 40 to 60 is at that area. So, excuse me, 20 to 40 is what's here. Depends on which text you look at. But that whole Purkinje network can be a pacemaker of its own if we need to. So there's redundancy in the system. The heart will back itself up. Now, unfortunately, when you get down to 20 and 40 beats per minute, you may not have enough cardiac output going on at that time to actually maintain perfusion to the brain. So if you're getting this area, you may be seeing changes in level of consciousness as you go through. Now, we talked about the electrodes. The electrodes are just a way of converting, taking that electrical energy that the heart is putting out, taking that, capturing it, and transferring it to an electrical machine so that we can get a graphical representation of the heart rhythm, okay? So really, all those are, and they need to have good contact. One of the things is you're putting those on, making sure that you look at the correct areas to place those on. Each hospital uses a little bit different system. So you can have a 3, 4, or 5 lead system as far as doing cardiac monitoring. And it's going to depend on what facility you are working as to which type they use. So we're not going to try to get you oriented to one, but you need to have a good understanding of those. Those are designed strictly for assessing and monitoring for cardiac dysrhythmias. Those are not designed for doing 12-lead EKGs, looking for heart muscle damage, and we'll talk about the 12-lead EKG. That 12-lead EKG, now there's been a lot of confusion. Let me back up. With 12-lead EKGs, there's not 12 leads placed on the body when we look at a 12-lead EKG. 12 leads means we're looking at the heart from basically 12 different angles, okay? So there's not 12 leads that are placed on the body. There's 10 when you look at doing a 12-lead EKG. 3 or 5 lead systems, again, bedside monitoring telemetry. Those are the ones that we're going to be using on our telemetry units and our cardiac units and our ICUs. These are designed for really monitoring for dysrhythmias, okay? Monitoring for dysrhythmias. The 12-lead EKG is a diagnostic test looking for muscle damage in the areas of muscle damage that have gone on as a relationship to that loss of blood supply to that muscle tissue. So that 12-lead is a diagnostic test. Now, most of you have seen that I've posted for you the areas where to place the 12-lead lead placement as part of the simulations. Guys, look at that. Kind of get an understanding for that as we go along. You may see that again. We talked about the leads. I'm not going to go through this quite as intently because, again, it's going to depend on where you're working and what type of system you're using. On SimMan, we're using a 4, and here we're going to be using a 4-lead. Where here's a 3-lead. But basically the 4-lead, if you look at it, and most of the time the leads are going to tell you on them. They're going to say RL for right leg, RA for right arm, LA for left arm, and LL for left leg. Now typically you don't put them on the limbs because of movement problems, but they typically will go on the chest wall themselves. Okay, so you will just put them on based on that. Most of the telemetry systems are actually going to have on the box themselves where they want them placed. So as you can see, but typically you're going to have white over green, black over red in a 4-lead or a 5-lead system. With a 5-lead system, the brown goes in the middle, and that will move depending on what lead the telemetry unit likes to monitor. Okay? Typically, in monitoring these patients, we like to use lead 2. Lead 2 gives us a good feel for the P waves and for the QRSs. It really helps us monitor for those dysrhythmias. But this is particular. You know, clouds over grass, smoke over fire. One way to remember, white over green, clouds over grass, okay? Or smoke over fire, black over red is one way. I saw one book, snow on tree, okay, for the white over green. Whatever acronyms or ever how you want to do it, to remember it is fine, as long as you kind of get a good idea of where they need to go. Again, just another 5-lead system. EKG monitoring paper is the graph that we're going to be looking at for these patients. Most of the time we're looking at this going across like a computer screen, or used to be an oscilloscope. When I first started working, we used what was called an oscilloscope. Okay, that tells you how long it's been. But I worked in a hospital that didn't have a lot of new equipment. But you would basically see one QRS go across at a time. It didn't give you like you see now. And it was very difficult to monitor, so you did a lot of running papers so you could see. Thank goodness for technology and what we have now, how great it is, and how good the computers are at analyzing not only rhythm strips, but 12-lead EKGs. Now, you don't depend on those machines. You have to understand how to do it yourself. But they are amazing when we look at some of the things we look at. And EKG paper will depend. The color is going to depend on the monitoring system you use. Don't worry about the color. Most of them are marked with 3-second intervals. Okay, there should be let's see if I've got one. You should have areas that are marked on the paper, and typically you'll have a mark like this and this. It could be on the bottom. It could be at the top. But they're marked in 3-second intervals, okay? And then typically what we're going to be looking at is a 6-second strip. A 6-second strip. The reason we use 6 seconds, why do you think we use 6 seconds? It's 1/10 of a minute, okay? So it's real easy using 1/10 of a minute. It's pretty easy to multiply by 10, right? Just add a 0 to the end of it. So when we start looking at rates, you'll understand. Now, if by chance you don't have the markings at the bottom, 30 of these small blocks, here to here, will equal 6 seconds. So 30 of the small blocks will equal 6 seconds. When we look at the EKG paper, we've got to have a representation here. We have what we call well, that's good. We have what we call the large box, which is this area here, from here to here. And then we have the small boxes, which are the little small boxes inside that one. So if we pull it out and look at it, basically as we look at this larger box, okay, the larger box here represents 0.2 seconds. 0.2 seconds. The blocks inside, okay, so you're looking from here to here, is 0.2 seconds. If you look inside, okay, that is 0.04 seconds because there are 5 boxes inside that square. Okay. Important as we start measuring PR intervals, those type of things. Those are things you're going to need to know as we look at these rhythm strips. Remember, as we're looking at the graphic paper, it's graph paper. Along the horizontal axis is time. Along the vertical axis is amperage. Okay? We're not going to get into doing a lot with amperage as far as reading rhythm strips. Amperage more is going to come in as we're looking at 12-lead EKGs. But do understand that amperage goes up and down on the vertical axis. Okay. Just another representation looking at a rhythm, at a EKG monitoring paper. I think we about beat that to death. What are we looking at? We're looking at a representation, a graphical representation of the electrical activity of the heart. This is not a representation of the mechanical activity of the heart. This is a representation of the electrical activity of the heart. What we're going to be looking at is what we call the PQRS-T complex, okay? We're going to look first at the P wave, okay? The P wave represents what? Atrial depolarization. Atrial depolarization, okay? P waves typically in lead 2, and the rhythm strips that I'm going to be giving you guys on the test will all be in lead 2. I will make it easy. I'm not going to try to switch leads on you or anything. They will all be in lead 2, okay? So in lead 2, the P wave should be upright and rounded, okay? Should be upright and rounded, a normal P wave, okay? The next thing we're going to look at is the PR interval. The PR interval. The PR interval begins at the upslope of the P wave, ends at the first deflection, okay, of the QRS complex, whether that is a Q wave going down or whether you have an R wave going up. But basically a PR interval goes from here to here. Okay. Now, you can see that can be very difficult to measure if you're looking at these small blocks of paper, okay? And it takes time and practice to get good at it, okay? Next thing we're going to look at is the QRS complex. QRS complex. Now, when we say QRS, you may have a Q wave, you may not have a Q wave, okay? You may have an R wave, or you may not have an R wave, okay? You may have an R prime. You may have, there's several different ways that it can present to you. It is still called a QRS complex, okay? These are the main things that we're going to be looking at is the P wave, the PR interval, the QR complex, and then we're going to look at the T wave, okay? Tell me what the QRS represents. Not the QRS. Ventricular depolarization. Now tell me what the T wave stands for. That, okay. The T wave is the repolarization. Now we do not see the atrial repolarization because it's actually hidden in that QRS complex there. So we have atrial depolarization, ventricular depolarization, and then ventricular repolarization as we look at those. There you may see a U wave. At our level, I really don't want to get into the U waves that much with you guys. That's more advanced type things. We're going to do basics, okay? Basics. But you could possibly see a U wave. Now, as we look at this T wave, we need to also look at this ST segment portion here, okay? This ST segment. Typically, that ST segment should be at what we call baseline. If you look at this strip, you've got the baseline going right along here. Changes in that ST segment up or down can indicate problems, okay? And let's see, I think I have. No, where'd it go? Okay. We'll go back to it. I think it's later on we'll talk about that and everything. But this is just another type representation of what we've been talking about. I just put some different slides on there for you so you can look at them as you're studying. But ST segment changes is something we need to look at. Elevations in the ST segment typically indicate ischemia. Ischemia, okay? Am I saying that right, guys? And typically represent infarction, okay? Muscle damage, okay? You can see ST depression with ischemia. Let me get it right. Depression with ischemia. Up means there's muscle damage. Up's infarction typically. Now, lead 2, because as we look at 12 leads, it can be different, okay? Okay. D is depolarization, okay? It's ventricular depolarization. The T wave is repolarization, okay? So looking at these, when you see ST elevation, you're worried about that patient's having a heart attack, okay? Okay. Now, sometimes with angina attacks, because we are getting a little bit of ischemia, you can see some ST depression in these patients, okay? ST depression. Now, you can also see what's called a digoxin effect of the ST segment, which is kind of like a a scoop-type appearance of that ST segment. So those changes, you can see those changes. But what we're going to be concerned about are the P, the QRS, as we look at this, as we start looking at rhythm strips, okay? That's the main things we're going to be concerned about as we're going along. Okay. All right. Let's just go through. The P wave's the first wave produced by an electrical impulse from the SA node, okay? Typically, it should be smooth, rounded, and an upward deflection. And we're talking, again, lead 2. It's the depolarization of the left and right atrium, okay? Guys, all of this is, you should have all of this in your notes, okay? The PR interval, again, is basically the PR interval is measured from the beginning of the P wave to the beginning of the QRS complex. It represents the time that takes the atrial and AV node depolarization. Really, it's that electrical activity traveling from the SA node down to that AV node, down through that AV node, okay? Normal duration of the PR interval is 0.12 to 0.20 seconds. 0.12 to 0.20 seconds. Anything shorter than that, anything longer than that is an abnormality. And we'll be talking about more longer than 0.20 seconds as we begin to look at the QRS formation, okay? The Q wave is actually the first downward deflection when you look at this complex, okay? And you see we actually have a slight downward portion here. The R wave is the first upward deflection, okay? Typically, it's the largest deflection seen in leads 1 and 2. And then the S wave is the downward deflection after the R wave, okay? So when we look at the QRS, we're looking at those things, okay? So Q wave is downward, R up, S down. Now, a Q wave can mean several different things. And those are looking more at 12-lead EKGs. So as we really begin to look at these look at different things, as you progress on in your studies, okay, Q waves will become more significant because those typically mean an old infarction or an old MI as we're looking at 12-lead EKGs. Now, really can't tell most of the time from looking at just a rhythm strip, but that's a 12-lead EKG type issue. Okay. The QRS complex basically represents conduction of the impulse through the ventricular muscle. That is ventricular depolarization. Okay. Remember, all of this is electrical activity, not muscle activity. Okay. Electrical activity. So that QRS complex represents ventricular depolarization. Okay. Following the QRS segment, basically we have the T wave, and that T wave represents ventricular repolarization. Should be slightly rounded and a positive deflection. In other words, it should be upright. Okay. Basically, this is the resting phase of the heart. And that T wave becomes important because if we get into some of the pathophysiology and type processes. If you stimulate that T wave to get a stimulus in the heart too early in this resting phase, you can send the heart into ventricular dysrhythmias, whether it be VTAC or VFib. Okay? So you may hear us talk about later on, as we're talking about things, something called the R on T phenomenon. R on T phenomenon. Okay? That's basically where we have an electrical stimulus falling within this resting phase, okay, and sending that heart when it's really not fully depolarized, okay, fully repolarized, okay, and then it will actually cause that heart to go into a dysrhythmia at that point in time. And we talk about that when we talk about synchronized cardioversions, those type of things a little bit next semester. So the summary, you can read all of this, but basically as we're looking at this, the P wave, the QRS, and the T wave are really what we're going to look at as we begin to look at those, okay? General rules, okay? First and most important, okay? Look at your patient. Don't treat the rhythm strip. Don't treat the strip. Treat your patient, okay? That rhythm strip is a part of your assessment of the patient, yes. But you can have a straight line, asystole looking rhythm strip, and walk in and your patient's standing there talking to you. Well, don't hit him in the chest to give him a precordial thump if he's talking to you, okay? There's a lead loose somewhere. There's battery is dead. Something's going on. So treat that patient, not that rhythm strip. Always assess your patient, okay? Read every strip from left to right, starting at the beginning of the strip. Read from left to right, just like we normally read. And then as we do the rhythm strip, we're going to use a 5-step systematic approach to looking at each strip. Now, some books will say 7, some will say 6, and we kind of combine a couple of steps together as we look at this 5-step. But if you'll follow a systematic approach to looking at rhythm strips, you will see that it makes it very easy, okay? So when we look at this 5-step method, first thing we're going to do is look at the rate. What is the rate? If it's below 60, it's what? Bradycardia. If it's above 100, so you've got something already taken care of, okay? So if it's in that 60 to 100 range, that's kind of a normal rate, right? Okay? We're going to look at the rhythm. Are the P waves regular? Are the QRS regular? Okay? Do they, quote, march out as we begin to look at it? And we'll talk about how to actually look at the rhythm of that. We're going to look at that P wave. Remember we talked about the P wave needs to be upright, okay, and rounded, okay, in lead 2. So we're looking, is that P wave there? First, number one, is there a P wave? If there is a P wave, is it upright and rounded? Is it kind of flat? Is it inverted? What is going on with that P wave, okay? We're going to look and see, is there a P wave for each QRS complex? Is there a P wave preceding each QRS complex? That's one of the things we want to do is we look at that P wave. We're going to look at that PR interval. What was the normal duration of the PR interval? 0.12 to 0.20 seconds, okay? So we're going to measure that PR interval. If that PR interval was within that time frame, it's normal. Is it consistent? Does it stay the same amount of time or same length throughout that rhythm strip? Okay? Does it stay 0.16 seconds throughout that strip? Or is one 0.12 and another one's 0.28 and another one 0.24? Okay? Are they inconsistent? That's one of the things. You can't just measure one PR and then go on from there. Now, a lot of times you can look and see that there's a big difference in those, and you can make from there. Then we're going to look at that QRS complex. One of the things I didn't cover on that slide back, the normal duration of a QRS complex, it's going to depend on which book you read, okay? I think your book says basically from 0.4 to 0.04 to 0.10 seconds. Okay? I was taught anything greater than 0.12 seconds is abnormal. What were you guys taught as far as the QRS complex? Anything over the point. And I think this book it talks about normals being 0.04 to 0.10, but then they talk about being abnormal at 0.12. So it's a little confusing, okay? For testing purposes, if it's greater than 0.12 seconds, which is how many blocks? 3 little blocks, okay, it is abnormal. Anything greater than 0.12 seconds or 3 small blocks for the QRS complex is abnormal. Okay, just so that we're all working on the same sheet of paper. Does that sound okay? All right, very good. We're going to look at that QRS complex, okay? Are the same shape and size throughout that rhythm strip, or are they different looking? Is there a QRS complex following each P wave? Okay, we're going to be looking at those type of things. Is it wide looking? Is it bizarre looking? Is it just what we used to call an FLB, a funny looking beat? Okay, so we will look at all those as we begin to look at analyzing these rhythm strips. Okay, so step one. Step one, the heart rate, okay? The way I want you guys to learn for basic type rhythm strip recognition is basically count the number of P waves and the number of QRS complexes in that 6-second strip and multiply it by 10. So you'll take a 6-second strip, you'll count the number of P waves, multiply by 10, that will give you your atrial rate. For the ventricular rate, count the number of QRS complexes in that 6-second strip, multiply by 10, that will give you your ventricular rate. Number of QRS complexes. So, that being said, if I give you a test question, and I say the ventricular rate is 75, do you think you might choose that answer? No. Why? Because the way you're doing it, your rate should be in multiples of tens. Now, will the rhythm strips, will the computers give you a more accurate reading? Absolutely. They use this formula for calculating that, okay? There are other ways to count the rhythm or the rate on rhythm strips. And I'll show you those in a few moments, okay? But I'm not expecting you to learn it. If you know another way, that's fine, okay? Because if you're more advanced and you work a CCU, you want something more exact than that 10 interval, okay? But for most part, what we're doing, being able to actually calculate within that 10 will do what we need to do as far as doing the rhythms, okay? Okay, so we're looking at it, okay? So we know that if the SA node normally discharges between 60 and 100 times per minute, so if our rate's between 60 and 100, we're within that normal range, okay? Does that make sense? You follow me? If it's less than 60, it's bradycardia. If it's more than 100, it's tachycardia, okay? Now, we talked about with that rhythm strip, remember looking, we have 3-second marks on those rhythm strips. The rhythm strips that you will have on your test, okay, will have those markings on there. So you don't have to count out 30 blocks, okay, and then count your number of QRS complexes that are in there. I will make sure those markings are on there for you so you can see those. So it'll make it a little bit easier for you. Again, we're doing basics here. We're not teaching advanced cardiology. If you want to learn advanced cardiology, all right. We can help you with that later on. But this is basically looking at a rhythm strip and looking at counting the rhythm, or the rate, okay? So you can see we have a mark here, a mark here, a mark here. So there's 3 6 seconds. So 1, 2, 3, 4, 5, 6, 7, 8. So what is our rate? 80 beats per minute. Okay? Pretty simple, right? Should be the same. Now, we could count our atrial as well. 1, 2, 3, 4, 5, 6, 7, 8. So our ventricular and our atrial rhythm is the same, okay? So we basically analyzed this for rate already. So we know this was within that normal range, okay? So we know we're within normal range on this rhythm strip. So you've gotten past the first step. That first step's easy. You can do that, correct? All right. I like that. All right. Another way to determine the heart rate is the R-to-R interval, okay? I don't expect you guys, I'm just going to go over this briefly, okay? You don't have to learn this part, but just you may see someone doing it this way, okay? I thought I had better, there we go, okay? And this is the way I do it, okay? So I can get a little more accurate. But basically you find a QRS complex that falls on one of the dark lines. And then you just count down to where the next QRS complex is. So if you look at this, there's 300, 150, 100, okay, 75. Well, I know that if I'm going from here to here goes from 75 to 100, that's 25, right? So then each little block is going to count for how many? 5. So I know I've got 75 plus 5, I've got a rate of 80. That's okay. You don't have to, okay? I'm just showing you this is another way to do it. Don't get confused. If you can count 6 seconds in a... Okay, 6 seconds, okay? How do you guys do it? Do you do it this way? Do you do the 6 seconds? Or do you count the number of blocks in between and divide by 3,000? And there's another long formula. Or do y'all cheat and just read it off the monitor? Uh-huh. Okay. What's another way to check the rate? There you go. Count the pulse. Assess your patient. Okay. Because, you know, you're going to look at this and you're going to count the pulse. Do they match up? Now, sometimes they won't. And when we talk about something called PVCs, you'll see why the pulse rate and the monitor rates might not match up. Okay? Okay. Next thing we're going to look at is the rhythm. We've got the rate down. We know how to calculate the rate. We know how to calculate the atrial and ventricular rates. Okay? We know if it's less than 60, it's bradycardia. If it's more than 100, it's tachycardia. So now we're going to go in and look at the rhythm. We're going to look at the rhythm of both the atrial and the ventricular portions of the heart. Okay? Basically, they're classified as either regular or irregular. That's not too hard. 2 classifications. With the regular rhythm, the intervals between the R waves or the P waves, whichever one you're measuring, are regular. They basically are marching out, and I'll show you how to do that also. If they're irregular, they just don't match out. You may be short here, long here, short here, and it just doesn't match out as you're looking at it. Okay? All right. Yes, ma'am. To the next R wave. And I'll give a demonstration, okay? That's not a problem, okay? So, guys, don't try to eyeball it. Don't look at that rhythm strip and say, yeah, that looks regular. Now, there are some that you can look at and you can definitely say, that's irregular. I know that's irregular. You don't have to do anything. But when you're trying to look at the regularity, really don't try to eyeball it. There's several ways that you can do it. You can use calipers. Okay. A set of calipers. If you want to take a look at these, they have some in the lab. Ms. Middendorf will let you play with it and get the feel for it, okay? And we'll put a strip on the document cam in a few moments. You can also do the paper and pencil, which is what I recommend that you guys will be doing during your test, because I can't let you have the calipers during the test. Sorry about that. Okay? And then there's the counting method. Now, that counting method gets rather tedious as you're trying to count the number of little bitty blocks, those small blocks between each QRS complex. Not what I recommend, okay? For you guys, this paper and pencil is going to be the easiest way to look for the rhythm of the strip. Okay? Let me grab. Because I can't do it on there. You just can't see it. Should I pause while I'm doing this? Document camera. Excuse me. And we'll do some more of these. All right. So we basically have a rhythm strip. You can see at the bottom your marks for the 3 seconds, correct? So looking at this, what is your rate on this one? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So 100. So we know that this is a tachycardia, okay? So we all know that. Is our atrial rate the same? So our atrial rate is the same, okay? Now we're going to look at the rhythm, all right? A couple of ways you can do it, okay, is you can use calipers. See if I can do this so you can see it. You take your calipers, put one caliper point on the QRS, and then just kind of march it out. And I'll move these a little bit every time, but you can see it's pretty consistent as it goes through. Now you can have a little bit off, okay, and it's okay. When we're talking about one small box off, you can still call it regular. Now you guys aren't going to have calipers, okay? So what you're going to do is take a piece of paper, okay? You're going to flip up one of the sheets of your paper, or I may, we'll do that. And then you're just going to take your pencil, and of course that was done right. Okay, you mark all 3, and then you just slide it down. Can you see how they line up? Okay. That's a way to check and see if it's regular. Would you say this is a regular rhythm? Okay, and it's as simple as that, okay, to check the regularity of a rhythm, okay? So that's all you really have to do. Again, you can sit here and count, let's see, there's how many small boxes? My eyes will not do that, okay? I cannot see it well enough to do that. So that's just one way that you can, the easiest way to do it is just take a sheet of paper, draw 3 tick marks on it with 3 QRS complexes, and then move down that whole strip to see if it's regular. Yes, ma'am?
I was just wondering, are we going to have more time on this test?
No, ma'am.
So we have to draw lines. We start shooting that one.
Yeah, you can do it. You can do it. Yes, ma'am. Say again. Up to 10. Okay. Y'all like that number back there in the back? How about 30? Your paramedic colleagues back there want 30 strips, okay? Okay. Now, I have to be honest with you, okay? On some of these rhythm strips, guys, listen to me. Listen to me. Let me get your attention. Look right here, okay? Those rhythm strips, on all those rhythm strips, you're not going to have to sit down and do all this stuff to those rhythm strips. Some of those are going to be visually recognizable strips, okay? Visually recognizable strips. The strips you should be able to recognize just visually, okay, would be ventricular tachycardia, ventricular fibrillation, asystole. You should be able to recognize those just boom. You look at that and you know what that is, okay? Everybody can recognize asystole, correct? Straight line going across, okay? So if you see a straight line going across, you're going to assume asystole, right? Huh? No, I like that. Very good. You're going to do what? You're going to go check your patient, okay? But that strip may look like asystole, okay? But there'll be strips. There are some strips that are just so easy to recognize, guys, as you get into this, that it will be real easy. It really won't take you that long. Now, I'm not going to, in all of these strips, okay, in all of these strips, you're not going to have to sit down and tell me the PR interval is, or the QRS is on all of these strips. A lot of these will be looking, what is the treatment for this rhythm strip? How does this dysrhythmia affect your patient? Because the whole thing is, what is it doing to your patient? What do we need to do for the patient? Okay? That's what this is all about as we look at it. Okay. Yes, sir. We will be covering, his question is what different types of rhythm we're covering, okay? And just to make it clear, sinus rhythm, normal sinus rhythm, sinus Brady, sinus tach, okay? Okay. PACs, multifocal atrial tachycardia, or PSVT, okay? We'll get there, okay? Then we're going to look, that's the atrial rhythms we're going to look at. We will talk a little bit about sinus pause, sinus arrest, sinus block. I'm not going to give you any of those on the, although a sinus pause would be real easy strip for you to pick up. But then we'll get into the blocks, okay? We'll get into the junctional rhythms, okay? And then we'll get into PJCs, okay? And then we'll get into the first degree, second degree, third degree heart blocks, okay? We'll talk more extensively about those next semester as we talk about pacemakers, okay? We're going to whet your appetite for those because you will see some of those on HESI. Typically, I had not been covering those because I really liked grouping that with the pacemakers next semester. But we found out that HESI is putting some of that on the test, so I wanted you to be introduced to those rhythms, okay? Then we'll talk about the ventricular rhythms, okay? PVCs. Premature ventricular contractions, bigeminy, multifocal PVCs, okay, VTAC, VFib, and asystole. Some of the two atrial rhythms I did not mention were atrial fibrillation and atrial flutter. So you can see we've got a lot of strips to cover between now and 1 o'clock. All right? Let me say again. We'll talk about it, okay? We'll talk about idioventricular a little bit as well, okay? But remember, we still have all the other stuff that's on the test as well. The MIs, the cardiac catheterizations, those lipid panels, the risk factors for cardiac, all of those. So, guys, it's going to be a comprehensive cardiac. Yes, ma'am. Have you worked through all the ones in your workbook? Yep. Okay. I don't know if I can get some or not. I can see. Just time-wise right now is just pushed. Okay. So we can see. Let's switch this back up. You'll have all the ones that are in my lecture notes. Okay. So we've checked about the rhythms. Okay. The intervals can, basically vary by 0.06 seconds. Typically, if they're getting more than one block, I'm getting concerned. One of the small blocks, I'm getting a little bit concerned. Is it regular, irregular? But you can see that respirations can cause some changes in the regularity. So irregular type rhythms, we've talked about basically. When we look at irregular, we're going to talk about regularly irregular, occasionally irregular, or irregularly irregular. Okay? Irregularly irregular. There's one strip that really fits that irregularly irregular type process, and that's atrial fibrillation. Okay, regularly irregular can be like a sinus, with sinus arrhythmia, which goes along with respirations. Occasionally irregular basically can go along with PACs, PVCs, those type of things. All right, take a look at this one. What's your rate? 60, okay. From looking at it, I know to tell you not to eyeball, but just eyeballing it, would you say it's regular? Yeah. And one of the reasons you can kind of tell it's regular is if you look at where the QRS complex, it falls on this line right after. Same thing here. You see the dark line. Then you see the small box here. It falls there. Same thing there. Same thing there, 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 and there. Okay. Huh? 60 is a Brady. It's a Brady. Okay. I'm not going to give you anything that's that close and make you make a judgment call on that. Okay. That's cruel and unusual. Okay. So we won't do that. But basically, you can look. Is there a P wave for each QRS? Is there a QRS following each P wave? Okay. If we could measure that PR intervals, probably maybe about 0.16 to 0.18, just eyeballing it there. So that's within that normal type thing as we begin to look at it. Okay. So again, just practice. There's several of them on there for you to kind of practice with. When we look at the P waves, okay, are the P waves present? Okay. Is there a P wave there for each QRS we talked about? Is the P wave upright? And is there a QRS complex for each P wave? We've kind of talked about that. You're looking for that correlation between the P and the QRS. There should be a correlation between the P wave and the QRS. Okay? Always, if you've got a normal strip. Yes? Some have negative deflections. Okay, if it's negative deflection, you're going to hit wherever that point is where you're going to measure from. Okay, so are you talking about measuring the PR interval or what?
I'm talking about the abnormalities that go below the line. You know, you had that straight strip and all of the
The
R.
Uh-huh.
You were measuring all of those. So then at the bottom of that, when you have some stuff that goes below the line, then it comes back up and corrects itself. And then
I'm not sure. Talk to me after. We're going to have to look at something. I'm not sure what you're saying. And as we look at some more strips, maybe it will come clear to me what you're asking, okay? So we look at the P wave analysis, the 5 questions asked about the P waves. Are they present? Are the waves occurring regularly? Is there one P wave present for each QRS? I think we've covered all of this, okay? Are they smooth, rounded, and upright in appearance, or are they inverted? Inverted P waves typically will indicate a junctional rhythm. And do all the P waves look similar, okay? Do they have the same appearance throughout that rhythm strip, okay? Okay. And we've kind of looked at that. That's the same strip we've kind of looked at before. And we can see we have P waves for each QRS. They're all upright, rounded. All of them are similar throughout the strip. Okay. The PR interval, again, we've talked about measured from the onset of the P wave to the onset of the QRS. Normal intervals 0.12 to 0.20 seconds. PR intervals greater than 0.20 seconds, that is considered a first-degree AV block, and we'll talk more about that. If it's greater than 0.20 seconds, typically if it is 0.20 seconds or above, it's considered a first-degree AV block. Those PR intervals we're looking, are they consistent across that strip? Okay, it's the same distance across that strip. Is every one of them 0.20 seconds as we'll go across? If they're shorter, then we can get in some different type things, and we're not going to really focus on that today. Something called Wolff-Parkinson-White and some different type things with that. Again, practice strips. Guys, work on these practice strips, and we'll come back. Again, most of them are pretty much the same as we go through. Step 5 we're going to look at is the QRS complexes. Okay. Remember we talked about the first negative deflection is the Q wave here, okay, going down. Then you've got the R going up and the S wave coming down. Now, is this what you're talking about, Claudette, where it comes down like this?
Yes, sir.
Okay. You're going to measure from the R wave, from the prime here.
So it doesn't matter if it drops below that?
It doesn't matter. Okay. Now, you could actually measure them all from right here and check the regularity as well. But typically, you're going to measure on that R wave, the first upward deflection. If there's not an upward deflection, there's only a Q wave, you'll measure at that point, that junction where it's down here at the bottom. Okay. So
I thought the baseline was where that part right there.
this is the baseline right here.
So I thought anything that deflected from the baseline was going to be an abnormality.
No, not necessarily. Not necessarily. I think she's talking about ST, yeah, and we don't even have an ST there yet right now. Okay, so we're looking mainly at this QRS complex is what we're looking at as we're looking at these rhythm strips right now. So we've gone through all of this as we go along, and we've talked about that. Questions you want to ask yourself: are the QRS complexes similar in appearance across that strip? Is the QRS duration between 0.04 0.10 seconds? Okay. If their intervals are greater than 0.12 seconds, we consider that wide and abnormal. So anything greater than 0.12 seconds for the testing is considered abnormal. Okay. Now this is some of the different QRS complexes that you might see. Okay. This is called an RR prime type QRS complex. Okay. Even though you have a small negative deflection here, which would be the Q wave. You have an R small downward and an R prime types. You may see that. You have a small upward deflection. Your S wave comes down and it goes back up. Okay, you're going to see various types. Okay, you have this one. The R goes up, goes way back down and across. What you're looking for is just that whole QRS complex. Then you've got a Q wave here, going up to the R. And this is a QS where you really don't have an upward deflection or an R wave. Okay, that's typically on a 12 lead. That's indicative of an old MI type process, depending on where it's located. So you can see all types of variations of those QRS complexes. The main thing is pick a point to check your regularity. You could pick here or you could pick here. Okay, to check it as you're checking the regularity of the strip. Okay. You could check from this point, or you could check from this point. It really doesn't matter. On this one, you're going to check from here to do your lines and check it as it goes across. Okay? Does that kind of answer, Claudette?
Yes, sir.
Okay. All right. The ST segment, again, that basically is what we're looking for ischemia or injury. Okay? If it's elevated or depressed, can indicate ischemia or injury. And again, we're not going to get into the whole big process of looking at 12-lead EKGs, but this is pretty typical of something that you're going to see with ST elevation that really is indicating injury to myocardial tissue. Okay, really, really big things. And you'll hear some people talk about the tombstone appearance of the ST segments, and that's where it's really high, and basically it's coming off right at the very top of that QRS complex. Okay. Depressions, typically you can see that in someone who's having an anginal attack, or maybe someone that's not evolved into the MI yet. You may see it go from here. If you see it move from here to here, that's very significant because you're moving from ischemia into injury at that point in time. People with on digoxin, you can see this, especially if their levels are high on the digoxin, you can see that dip. Again, guys, I'm not expecting you to pick up on all of that at this point in time. Okay. Remember, the T wave is produced by repolarization and relaxation. It's commonly the first upward deflection after the QRS complex. We're not going to get into that. The U wave, again, just be aware that you may hear, if you're reading EKG reports, those type things, that you can see the U wave. A lot of times it's not visible. The actual cause or origin is not completely understood on that, but it typically follows that T wave, okay? And typically it's upright and has a positive deflection. Again, we're not going to get in. I'm not going to ask you to identify a U wave on an EKG strip, okay? Just so you know what's there. You can get artifact, okay? And that's one of the big things you have to be aware of as you're looking at strips. And is what I'm seeing the electrical activity of the heart, or is what I'm seeing artifact, okay? I think we talked about maybe last week or a couple of weeks ago, there on 3 East, the nurses were sitting at the station, all of a sudden looked up, and a rhythm strip going across a monitor looked like VTAC. They get up, take off, run down to the patient's room. They get down there, the patient's standing at the sink, brushing his teeth. One of his electrodes was not attached very well. It had gotten loose after he'd bathed and everything, and it was moving. So it gave that appearance of a ventricular tachycardia type rhythm, okay? So those EKG leads, those patches need to be on correctly. They must be moist. There must be a conductive gel in there. So if you take off the backing and it's dry, throw it away, get another one. If they're getting loose, take it off, put a new one on, okay? So that can give you several different problems. Don't see this as much anymore, 60-cycle interference, because with electrical equipment, we're grounding it much better, so don't see that very often. And you can have problems with EKG equipment, especially telemetry. Battery can die on it, okay? So you're going along, and all of a sudden you see a flat line, okay? Well, again, assess your patient, go down. It could just be the battery's dead on the telemetry unit. So there's some artifacts. See how that baseline is just, you can still see your P wave, your T wave, okay? But it's just not a nice, clean type thing. And that's probably from a electrode not having the gel in there and being dry. That's probably what that's caused from. Okay? What time is it? All right, let's take about a 10-minute break. We'll come back and we'll start in on the different rhythms.